everybody. Welcome to Being Kambua. My name is Kambua. I am so happy that you are here in this growing family of people who want to share their stories, draw strength from one another, learn together. There's so much that we've been learning through the seasons of this podcast. And of course, we are on season 4, and it's been such a great season so far. It's the year 2025, and so we come with different things, more information. And you people owe me. You owe me because the caliber of people I have been bringing who've been giving you information, you're like, leo umenisaidia. You owe me, but ninawapenda. That's why we do this. I want to say a big thank you to Dusit Princess for giving us this amazing space for us to get this production done, and of course to everybody who makes this podcast possible. Today I am joined by a man that I met maybe about a year ago, and you know, when I met him and just heard the passion in his voice for women and for saving the lives of women, I was like, this one has to be my friend. Dr. Kireki Omanwa, karibu sana.
Asante sana.
I'm so happy you are here.
I'm also happy to be here.
Yeah.
Thank you for inviting me.
Yes.
I've been waiting to see whether you'll invite me back.
Are you serious?
You've done well.
I've passed the test.
You passed the test.
Oh my goodness. I met Dr. Kireki when we were having conversations about maternal health.
Correct.
And at that time you were preparing for a run, for
yes,
a post-partum hemorrhage run.
Absolutely.
Yes. How was that? First, tell us how it was.
It was fantastic.
Yes.
It was fantastic. Just for the record,
Yeah.
that was the first time anybody in the world had organized a PPH, a postpartum hemorrhage run.
Yeah.
So we actually created history, and it was very well attended.
Yeah.
We had over 3,000 participants.
Wow.
We had a lot of support from the decision makers. We had, I think, 3 or 4 governors.
Yes.
There was Her Excellency Gladys Wanga from Homa Bay.
Yeah.
Her Excellency the Governor of Embu, Cecily Mbarire.
Yes.
There was Her Excellency from Nakuru, Kihika.
Kihika.
Yes.
Okay, yes.
Her
Yes.
Excellency
Susan.
was also there, Susan Kihika, thank you. And then we also had quite a number of MPs and women reps as well. So politically, it was very, very well attended.
Yeah.
We also had the Cabinet Secretary for Health herself. Okay. She also came. She came there.
Yeah.
And then we also were graced by the former CJ, David Maraga. So it was very well attended. We had very good exposure.
Yeah.
We got quite a number of university students and Kenyans who just wanted to come and support the run.
Right.
And we are almost starting to plan for the next one.
That's fantastic.
Yes.
Yes, and we'll be giving our people more information as it comes.
Absolutely.
I will share the information with me. I will share it with my people.
And we want all of them to come.
And we want all of us to come.
Yeah.
I should tell you that Dr. Kireki is the president of the Kenya Obstetrical, did I say that right?
Correct.
And Gynecological Society. It's such a mouthful.
They call us gynos or gynes or whatever.
Yeah. Gyno is so much easier.
Yeah.
Why did you choose this line of medicine?
Actually, it was by accident.
Oh,
I
tell us.
never set out to be an obstetrician.
Yeah?
Completely. I trained in Poland.
Okay.
And when I left Kenya, I got a Polish government scholarship to go and study. I thought I would be a pediatrician because I think I had come in contact with some gentlemen who were pediatricians, and I saw the way they were behaving with the children, and I thought this is a good thing to emulate, become a pediatrician. So first year medical school, second year medical school, I'm going to be a pediatrician.
Pediatrics, yeah.
And then I went, I got some contact while still in medical school. I think that was in third year. I went to a hospital and I was attached to a surgical department.
Okay.
And the first time they took me to theater, it was a shock.
Yeah.
You know, the patient is under anesthesia and completely helpless, and you're told, come and stand here. So you're the one who's going to hold, you know, to hold what they call retractors, so that the surgeon can operate well.
Yeah.
So I got hooked onto surgery. And I said, and I went there several times, I'm a foreigner.
Yes.
And they treated me very well, I must say. And the boss of the department actually told me, you know what, Kireki, we have known you.
Yeah.
You are consistent,
Yeah.
and you come when you call you, and even when we don't call you, you still come because you want to learn.
Yeah.
When you finish your medical school, when you finish your undergraduate, come, we'll train you to be a surgeon.
Oh, wow.
And I said, well, I'm going to be a surgeon.
Wow.
Until I went, after medical school, we have what you call internship. 1 year where you rotate through different departments.
Yes.
You go through surgery, internal medicine, you go through obstetrics and gynecology, pediatrics, and anesthesia.
Yeah.
So when I went for my my obstetrics and gynecology, it was a small hospital, call it a district hospital.
Yes.
And the team is a small, well-knit team, and very friendly as well. And of course, most of the time it was you observe, and then they help you, you assist in deliveries and so on.
Yes.
And then one day my colleague told me, today, this is your patient. So you're the one taking care of this patient.
Yeah.
From beginning till the end.
Yes.
I mean, you've been seeing what we do, so it's time you did that.
Yeah.
So, of course, I said, well, I never expected it,
Yes.
but there it was.
Yeah.
The training there is slightly different than here because, again, it's more structured in a way, and the cover, they have a good number of doctors.
Right, yeah.
So, that particular time, said, okay, today is the day. So took care of the patient.
Yeah.
So I'm the one who's measuring, how the pregnancy is progressing.
Yes.
I actually delivered the baby.
Wow.
I did an episiotomy. My hands were shaking. And
Oh, my goodness.
so I delivered that baby. It was like, what?
Yes.
And I said, okay, since you delivered the baby, you repair the episiotomy where we made a small cut to enable the baby to come out. Of course, that was the first time I'd done it. I had seen it being done so many times. Yeah. So in my mind, I could actually walk through it. I could do it. Yeah. But I never, done
actually
it
done it. Yeah.
So I sat there, I put the first stitch, the second stitch. You normally suture or stitch in layers.
Okay.
So I did the first layer, the second layer, the third layer. See, everything is coming on well, but my hands were shaking and I was sweating. That was the first time, just like anything.
Yes.
So by the time I finished, and then that was the light bulb moment that actually this is what I want to do.
Wow.
Because obstetrics and gynecology entails you have to have knowledge about internal medicine, and then you also have to have knowledge about surgical knowledge.
Right.
So it actually is two things in one.
Yes.
Then I realized, okay, even if I never did surgery, just pure surgery, here I'll also be able to do a lot of surgery, and we do a lot of surgery in obstetrics and gynecology. At the same time, we're also taking care of two people at the same time.
The mother and child.
And actually, I think, as they say, serendipity. I went all round, but I landed where I was supposed to land.
Yes, the path finally led you.
It's led me where
to
I was
where
supposed
exactly
to.
where you're supposed to
and
be.
I thank God for that because I love this profession.
Yeah.
And it gives me a lot of satisfaction.
So I was saying that it shows, and I think there's such a difference when you're doing something just as a job, and also when you're actually really passionate about it. And I'm grateful that there are doctors like you in the practice who are truly passionate about what they are doing.
Thank you.
So Dr. Kireki, before we get into what I really, really want us to talk about, in the years that you've been practicing, how many years has it been? Many? In the few decades, in the decades you have been practicing. What are some, can you think of something that's been a highlight for you that you would share with us?
A highlight. You see, when you ask a doctor what is a highlight, there can be actually very many highlights. But sometimes it can be the surgery you've done, maybe something that you've come across, and so on. What I think, and I still go back to it from time to time, we do a lot of surgeries, but then there's one or two surgeries which always remains somewhere
with you
at the top of your head, or at the back of your mind, as it were. It was actually, I think, maybe 2 years ago, maybe 1.5 years ago. I was called by my registrar. Registrar is a doctor who is training to be a specialist, and they told me, we have this patient. This patient had been sent from, I think, from Kambua. And she had a pregnancy, and the pregnancy was in the abdomen, not in the womb. because a baby grows in the womb, not in the abdomen. We said, okay, how many weeks? It's about 35 weeks, 35, 36 weeks. First of all, it's a miracle that the baby could grow all that time in the abdomen, not in the womb.
My goodness.
So the issue that she had been referred from Kambua is because they didn't have a lot of blood. Blood is one of the biggest problems you have in this country. So she came and they told me, she's having some pains and we need to sort her out. I said, okay, take her to theatre. Because I was a consultant on call and I'm the consultant, any complications on anything that is difficult, you are the one to deal with. So we went to theatre with my registrars, two of them, and we opened the abdomen nicely. And the baby is actually, you can feel it, the baby out here completely. And we got the baby out. As we are doing that, as a surgeon, you have to think, you have to have a plan B and a plan C. What if? What if? The biggest worry, the biggest fear is that when that baby grows outside the womb, the placenta is what connects the mother to the baby, is actually attached to the intestines.
Oh my goodness.
So that is a challenge. So we get the baby out. That was not the biggest issue. The baby was fine. 35, 36 weeks, about 2.5, 2.6 kilos.
Amazing.
Baby girl, beautiful baby girl. So we room the baby, and now we have to get the placenta out. We can't see it. So what do? We had made an incision, straight incision. And when you looked and saw we are not getting anywhere, make a bigger incision straight away. So made a bigger incision all the way. So we got lot of blood, very... But at that time, you're not thinking about that. You're thinking about, I need to get this placenta. Where is it located? And get it out. And luckily, we managed to get it. And, when they say we are wonderfully and beautifully made, it is exactly that way. God is a God of order. So we managed to get that placenta easily. We got we clamped where the blood was coming from and tied quickly because there is speed because you don't want her to die on the table because of the bleeding. So we managed to clamp and finish. And when we finished to get the placenta out like that, there was no more bleeding. We feel like, wow.
We did it.
We did it. We did it.
I have so many questions because I'm like, how did this baby... Does the baby not need like amniotic fluid?
Everything was outside. So the amniotic, what we call them,
was around the baby outside the uterus.
Outside the uterus, completely.
Oh
completely
my
outside.
goodness.
Completely outside the uterus. So once we had finished our bit, and we said we have, because patient care is the most important. So we need to get a surgeon in to also look and see whether, as the placenta was growing, whether it had infiltrated the intestines. So we got our colleague in who came and had a quick look, and everything was okay. And after 7 days, the mother went home, and the baby.
Wow.
Yes, the mother.
Oh my goodness. I don't know. That would stay with me for sure.
So that's sort of, it is very scary surgery because God forbid that placenta has infiltrated into the intestines, then it's very difficult to get it out. So normally we could leave it in there and then wait for the immune system to get rid of it. But again, that can also bring in other issues altogether. May get in an infection, may get sepsis, and so on. But thank God everything was fine. The mother went home and the baby, and
wow.
It's a miracle. It's a miracle.
Truly, it's a miracle. I don't know how to explain that. And Dr. Kireki, now that you've talked on some of the things, I want us to now land on, because we've talked about there was a possibility that she would bleed too much. I want us to talk about postpartum hemorrhage, which I was actually very surprised to know that it's a leading cause of maternal mortality in our country.
Unfortunately.
Why is it so high in our country? Why are mothers dying after giving birth?
Maybe let me take you a little bit back.
Please.
Maybe we may talk about postpartum hemorrhage, and somebody may not understand what is postpartum hemorrhage.
Please, break it down.
So maybe I can, sort of describe or define what it is. It is basically excessive bleeding after delivery. And this excessive bleeding after delivery can occur during normal vaginal delivery or even during cesarean section. How do we define or how do we know that now this is excessive bleeding? When a woman delivers vaginally, normally she may lose about 100, 200 milliliters of blood. But when that loss exceeds 500, then it is postpartum hemorrhage. It's excessive bleeding. That is vaginally. When we deliver women by cesarean section, they also lose blood, a little bit more than during normal delivery. And normally it's about 400, 500 milliliters. But when that loss exceeds 1 liter, then that is excessive bleeding.
How do you measure how much blood I'm losing?
There are different ways of doing it. Most of the time, we've been using, what we call packs. When we're operating, when there's a place that is bleeding, we put an abdominal pack to stop it from bleeding. And you see, it may not stop immediately. So that pack, soaks that blood. And if it is completely soaked, we remove it and we pack another one because we want to see what we are doing. It has to be clear of blood. So then we will look at the end of the surgery, we will look and count how many of those packs that we have used. These packs can sometimes be misleading because then it is basically visual. That's a visual sort of judgment, which can be completely off. And sometimes during normal vaginal delivery, the patient may bleed more, but our visual judgment may not be good enough. So you find a patient has bled excessively, but our vision, our judgment says no, it's not too much. There is something that we started using after doing quite a bit of research, and these are called drapes. And these drapes, every patient is supposed to have, those ones who are delivering vaginally, supposed to be put under the buttocks, so it collects all the blood that flows. And then the drapes, it has a container which is calibrated, which you can very easily see. It's more objective. You can very easily see this is 300 milliliters, this is 500, whatever, and make a quick decision. So that is the way we judge. However, when we are doing surgery, apart from those packs that we use, we have to continue communicating with the anesthetist. Anesthetist will say, the pressure is dropping. So if she loses a lot of blood, there are signs. The pressure starts dropping, her heartbeat starts getting faster, because now the heart is, I want to pump more blood, but this blood is not available. So we're sort of doing a compensation sort of mechanism. So we want to start beating a lot faster to push as much blood as possible, and that blood may not be there. So we can actually hear it when we're operating. So even as I'm concentrating here, my other senses are also elsewhere. I'm also listening to that heartbeat on that anesthetic machine. I'm also seeing that patient, how is she behaving? This blood, where is it coming from? So it is it's like a pilot. You have all these instruments, but here it's not really an instrument, but now it's a life, it's a human being. And when I'm doing that, I have to make sure that all things are working together.
Yes, as they should. And what would be the cause for a woman to have excessive bleeding?
Excessive bleeding. Thank you for that question. There are what we call predisposing factors. Number one, age is a factor. The younger women and the mature women. I don't want to say old women. They're not old women.
I know which side I'm falling on.
You're not anywhere near that. Don't worry.
We had a slightly advanced advanced maternal age.
Yes. So why is it that younger women or mature women will have this problem? For the younger women, when we talk about younger women, you're talking about, teenagers basically. 12, 20. 13, 14, 15, 16. And we also have a challenge with that in this country. Of about 200,000 teenagers get pregnant,
yeah.
which is not a good thing.
No.
Now, their bodies are not yet, mature.
Ready, yeah.
Their systems are not. That is number one. Number two, you find that their nutrition is also not very good.
Right.
So they start off with the anemia, and this anemia is a challenge later on. It's a predisposing factor for excessive bleeding later on.
Yeah.
Now, the other thing is that they also do not have. They have little or no information at all about the pregnancy and how to take care of it and so on. We had a case not too long ago, and again I was on call.
Yeah.
There was a patient, a young lady, I think 14 or 15 years, from, I think it was Thika or somewhere.
Yeah.
She came, she had never been to a doctor. So when she came to the hospital, she had started having contractions. So we decided, let us do a scan and find out, because we looked at the abdomen. It didn't look as if it was okay. It looked a lot bigger than what she was saying. So we were thinking maybe she could be having fibroids, maybe she could be having twins, that sort of thing.
Yeah.
So when we did the scan, what came out is that she had conjoined twins. So there was a baby and conjoined, and the babies were conjoined from the chest all the way. Wow. So with one heart, but 4 legs, and and so on. So she had no idea that is what she had. So had she continued, having labor, most probably she could have died. Why? Because the conjoined twins cannot come out. And if she labors for too long, she may get an infection. Right. And then, of course, she had anemia. And so with that anemia, even if she loses, 100 milliliters, she'll have excessive bleeding, postpartum hemorrhage, and so on. So age, younger age. Maturer women also have this problem. Them is because age is a factor, and their systems are, I don't want to say old, but their systems are, may not be able to adapt very easily to the changes that come during pregnancy. Having a big baby. So if a woman has a big baby, the uterus is very, very stretched. So by the time that baby comes out, the contracting, the mechanisms to make it go back to where it was, you find they're not working the way they should. The same thing if a woman has a lot of fluid, the fluid, the waters that surround the baby. Again, the uterus is also very, very stretched. If you have twins or triplets for that matter, I do IVF, I'm an IVF specialist, and we do a transfer, and sometimes, most of the time, we do a maximum of 3 embryos. And sometimes all 3 of them actually implant, and you have, you're carrying triplets. Again, the uterus is very, very stretched, and most of the time you find these patients go to around 34, 35 weeks. Rarely do they go beyond 35 weeks. If you have fibroids, fibroids are basically a growth. And just for your information, African women of African descent, 30 to 60% of women of African descent, it doesn't matter where they are, whether they're African Americans, whether they're in Cuba, wherever they are, we have a tendency of having fibroids. Number one, they are bigger in size, and usually there are very many. A colleague of mine removed 140 fibroids. In one woman, yes. Oh, I have removed 80, so I haven't reached that record yet. Now, if you have fibroids and you are expectant, first of all, these fibroids will grow with the pregnancy. And as they grow, they stretch again the uterus. So that time now when the placenta comes out, that mechanism of closing the vessels which are open where the placenta was, they are not there. So you find that they will be bleeding. And this bleeding goes into the uterus, and it has to come out as clots. So we have that. We also have injuries during delivery. Especially during normal vaginal delivery. So you may find injury to the vagina, for example. It's a big baby, becomes a challenge. And then we also have injuries to what we call the birth canal, the neck of the birth canal. So, and if this injury is not noted early enough, you'll find that this woman, she has delivered well, and if there was no assessment of the birth canal, you find there's going to be a problem. You also have an issue with with what you call clotting factors. You see, when you cut yourself, you bleed a bit, and then after that, it starts clotting, and whatever, you'll have a scar.
Yes.
Sometimes some women will have a problem with that clotting mechanism. Okay. So they have issues even when they cut themselves a little bit, they will bleed. So when it comes to delivery, naturally there will be a bit of bleeding, but this bleeding does not stop. So these are some of the things. And sometimes also some medications that we use, what you call blood thinners, and if they are not stopped in time, aspirin for example, we have what you call Clexane or heparin for that matter. If they are not stopped early enough, at least 24 to 48 hours before delivery, if she comes to deliver, she's going to bleed.
What's the difference between a fibroid and a cyst?
Thank you. Now, a fibroid, just from the name itself, it grows from fiber. The uterus has muscle fibers, smooth muscle fibers. So this one grows from those smooth muscle fibers. A cyst is basically a collection, a structure which has it can be fluid or it can be other substances. It can be clear fluid, it can be blood, it can be, there's what we call, for example, a dermoid cyst, which has fat, it has hair, it has teeth, and whatever, and so on. Can be a cyst which has, mucus-like structures. Or sometimes they can be mixed and so on. Now, and the cysts are usually either, in most of the time, when you talk about women, you'll have a cyst on the ovary or on the ovaries. And the cysts can either be what you call benign, they are non-cancerous, or they can also be cancerous as well.
Yes. Do they pose, do the cysts, like the fibroids, pose any danger to a growing baby in the womb?
The fibroids, yes, they can.
The fibroids
can. I want to answer is yes and no.
Yes and no, okay.
Yes and no. And I want to qualify my statement. Sometimes, yes, the fibroids can be a problem. First of all, in the woman getting pregnant. And also, once she has got pregnant, because remember, when the baby has implanted in the womb, there's a lot of blood which flows into the womb to supply oxygen and to supply nutrients to the baby. Now, as it is doing that, that blood is not restricted only to the baby. The fibroids will also take advantage of that. So they'll also start growing. Now, depending on where they are located, depending on the size, as they grow, they also stretch the uterus. So it will reach a stage whereby there's a mechanism, a contraction mechanism, which is sent to the brain. So it reaches, as the uterus has stretched to a certain extent, the brain tells the uterus that now it is time to do what? It's time to get rid of what is there, because that size is the right size. So you start having contractions. So you start having contractions now, may actually lead to either a miscarriage or either a premature delivery. However, we have seen patients, and quite a number of them as well, who, I had a patient whom I did IVF on some time as well. You know, those things you don't forget. I did IVF on her, I think about 5-6 years ago, and she had fibroids. So we had this discussion before. We said, look, you have 3 big fibroids, 5, 6, and 7 centimeters. I think it would be better if we remove them. And she said, let me go and think about it. So she thought about it, and she came back and said, you know, Daktari, tuendele. I won't remove the fibroids, but I know I will get pregnant, and I will carry the babies to term. So we did the IVF, got eggs from her, got sperm from the husband, created embryos, transferred them. There were 2 embryos only. And we transferred 2. And she conceived, she got twins. So when she got pregnant, I said, now, because the fibroids are also growing, and she has some pain, some discomfort, I said, because again, that's a mechanism. When the uterus starts stretching, the cervix starts opening. The cervix is the opening where the baby comes out through. She said, I think we should put a stitch around the cervix, such that to prevent it from, from opening. She said, let me think about it. So she went and thought about it. And she came back, she said, you know what? I don't think I'll go for the stitch.
Wow.
Informed choice
Yes.
is very important,
Yeah.
and that is what we try to teach our residents.
Yeah.
Discuss with the patient,
Yeah.
tell her the options,
Yes.
and tell her the the downside of whatever options that that are on the table,
Yeah.
and make that decision together.
Yeah.
So we agreed. We said, okay, if that's what you've agreed,
No
that's
stitch.
fine, no
Yeah.
problem. But now I'll be seeing you more often, such that if there's any intervention which needs to be done,
Yeah.
then we do that intervention now.
Quickly, yeah.
I remember what she told me. She told me, Daktari, you know what? Don't worry. I'll go to 38 weeks.
Wow.
I said, fine. And guess what?
Yeah.
There is something about women. Once you've decided, you
Yes.
focus on something.
Yeah. You will not stop us.
You get it? By the way, she went to 38 weeks.
Wow.
I did the CS
Oh,
after
my
38 weeks.
goodness.
38 weeks and 1 day.
Wow.
And later on, she told me, I told you. I said, okay, I hear you.
Yes, yes.
Yes.
Oh my goodness.
Yes.
And when you deliver the twins at this point, now
Yes.
do you now take out the fibroids?
No,
or-
you don't.
Oh, you
No,
don't.
you don't. Hey!
Okay.
That can actually lead to postpartum hemorrhage.
Really?
Remember that blood.
Yeah.
A lot of that blood. So
Yes.
the fact that we have removed the baby or
Yeah,
babies
yeah.
does not mean that blood it stops flowing straight away. So, and they're very, very, very well, have very, very, very good vessels.
Yes.
So if you try to do a myomectomy, removal of the fibroid, then most probably she will bleed to death.
Oh my
most
goodness.
probably.
Yeah.
So what we do, we don't touch.
Okay.
That is the rule of thumb.
Okay.
There can be exceptions
Yes.
whereby the fibroid is hanging on what you call a stalk. And you can see that this stalk is not too bad.
Okay.
You can actually tie it and remove it.
Yes.
But those are exceptions.
Yes.
But the rule of thumb
Yes.
is that don't remove. Even if the fibroid is in the line of incision where you're going to cut,
Yes.
try to look for an alternative.
Okay.
Yeah.
In cases where a woman has gone through surgery or a vaginal birth, and the doctor has checked her, everybody has checked her, she's good, everything looks good, she's discharged and goes home.
Yes.
And then, because we've had cases of a woman was taken back to hospital and she had internal bleeding, and everyone is
Yes.
like, how did that happen?
How did that happen?
What usually happens in
What
those
really
cases?
happens?
Yeah.
Many things can happen.
Yeah.
First of all, when you talk about excessive bleeding, it can happen to anybody.
Yeah.
Number one.
Yeah.
It can happen in public hospitals.
Right.
It can happen in private hospitals as
correct.
well. I have what we call pillars. And this is how I came about it.
Yeah.
Not too long ago, I was in one of the private hospitals. I had done a small case, and I had finished, and I was going away. As I get out of the theater, a colleague of mine is calling, said, come. There's serious PPH in theater 3 or theater 4, whatever it is. You know that is an emergency.
Yeah.
So I rush there. I find my colleague is actually struggling. There's this patient on the bed, and she's literally gushing
My gosh.
blood from the vagina. So I asked my colleague, what happened? Just a quick history. He said, it's a 31-year-old patient.
Yeah.
This was her second pregnancy. She had lost one pregnancy. But this pregnancy had been completely unremarkable.
Yeah.
And she had delivered a beautiful baby girl.
Yes.
3.1 kilos. So nothing really. And then when she checked, she checked the birth canal.
Yeah.
It was just a small tear in
Yeah.
the vagina
Yeah.
where she put 2 stitches. So
Okay.
there was really nothing.
Okay.
But then she's just continued,
Bleeding.
bleeding. So she has tried everything. When you remember we talked about a pack?
Yes.
Put that abdominal pack,
Yes.
and after 2 minutes, it's completely soaked. And it's coming out.
Yeah.
Another one, because now we don't exactly know what is happening.
Yes.
So I said, do you mind let me have a look? Because 2 heads are better than one.
Right.
And, I'm coming in with fresh eyes now.
Yes.
So I look, I said, check through the passage. Nothing really there. I could
Yes.
see the 2 stitches she had put in the vagina. And the cervix was okay.
Okay.
There were no tears there. So where is she bleeding from? The uterus, the next thing that we do is check the uterus whether it is contracted.
Yes.
Because again, it's a normal mechanism.
Yeah.
Once the baby has come out, the
Yes.
uterus contracts,
Yes.
and the bleeding should stop.
Yeah.
And the uterus feels contracted, but she's bleeding. So I put my hand inside and I try to feel, where could this be?
Yeah.
When I come out, it's just a few clots.
Okay.
So where is this bleeding from? But I felt something. It's as if at the back of the uterus,
Yeah.
there was a growth there. So my theory was that most probably there was a fibroid.
Okay.
And the placenta was actually, placental bed was on top of the fibroid.
Yes.
So those vessels that I talked about, once the placenta came out,
Yes.
the vessels were open,
Burst open, yeah.
and they were just pouring.
Oh my goodness.
So she had got all the medications. You know, this is the beauty. There was an anesthesiologist
Yes.
who actually knew what medications to give and so on. So I asked, I've given this, yes, I've given this, yes,
Yeah.
but she's still bleeding. And then you can hear, you remember that machine that I talked about? Tick, tick, tick.
Yes.
Say, goodness. So what do we do? Do we have something that we call a balloon tamponade? No, we don't have. What do we do? I say, give me a catheter. A catheter is that the tube that we insert
Yes.
in the urethra, in the bladder,
Yeah.
you know, to remove urine.
Urine.
I said, okay, give me a catheter. They brought me a catheter. They asked me the size. I said, whichever size, just give it to me.
Okay.
So they gave me the catheter, and I said, I need a condom.
Oh.
Somebody would ask, why do you need a condom
Yeah,
in
for
theater?
what in theater?
There you go. Even you ask me.
Yeah, tell us. Sure, my guys want to know.
They want to know. It's not for the purpose that people are thinking about.
We are intrigued. Tell us.
So I asked, do we have a condom? They say, there's no condom. They say, I need a condom. We need a condom. There's no condom.
Yeah.
And then one of the nurses walked out, and then after a few minutes, I think about a minute,
Yeah.
it could have been shorter. But
Yeah.
in that situation,
Yes.
it feels as if it's 10 minutes.
Yes, yes.
Meanwhile, she's pouring.
Oh my goodness.
So they gave me, she came and then she said, excuse me, I wanted to say
Yeah.
that I have a condom,
Okay.
but it was not in my handbag. I said, we don't care.
That's the least of our worries,
We
right?
don't care where you got it from.
Whether it was yours.
Wherever.
Yeah.
In any case, how can we check whether it was not in your bag?
But she's like, FYI.
Yes, for your information. So anyway, I said, just give
Yeah.
it to me. So basically what we did,
Yeah.
we improvised
Yes.
that balloon tamponade. We took the catheter,
Yeah.
inserted it in the condom and tied it. Once we tied it, we actually created a balloon.
Yes.
We inserted this balloon inside the uterus and then filled it with water, normal saline.
Yes.
Put in about 200, 250 milliliters of water.
Yeah. Yeah.
It stopped bleeding.
Wow.
And he said, okay, just to make sure
Yeah.
that she doesn't bleed again, we put in another abdominal pack, those packs that we use for surgery.
Yeah.
We put in another one there, and we said, let this stay in for 24 hours. Now, after that, she went to the ICU.
Okay.
When she came to hospital, her HB, what we call the level of blood,
Yeah.
was 11.1. When she went to ICU,
Yeah.
it was 3.1. So she had lost almost 2 liters of
Oh
blood,
my goodness.
or even more.
Yeah.
Because for every gram deciliter,
Yeah.
you lose about 300.
Oh my goodness. Yeah.
Now, we were very lucky with her. She was in a private hospital.
Yes.
There was human resource, there were personnel. There were 2 consultants, myself and my colleague, and there was a consultant anesthesiologist who knew what to do, what medications to give, and
Yes.
whatever.
Yes.
We had medications, that's the second pillar.
Yeah.
Whatever medications that we asked for, we got. Unfortunately, it's very unfortunate that some of the medications we use in this country
Yeah.
are fake.
Oh no.
It's very unfortunate, but it has been proven in a study.
Yeah,
We
yeah.
have the evidence.
Yeah.
There's what you call emotive study which was done, and it is recorded. Some of the medications that we use
Oh my
are
goodness.
fake.
That is
So
unfortunate.
in such a situation, you need medication to actually work on the uterus.
Yeah.
And then in that medication, it's supposed to be, let's say, 10 milligrams.
Okay.
And you find it is maybe 4 or 5.
Oh my goodness.
So you give it and then you wonder, why
not
is it
taking
not
effect.
contracting? Why is it not
Yes.
working?
Yes.
No, that sort of thing. So we had medication.
Okay.
We had blood.
Yeah.
In Kenya today, we collect about 270,000 units of blood.
Okay.
We need, according to WHO, we need 1% of the population, we need that kind of blood. What does that mean? Kenya has a population of about 50 million. So 1% would be about how much? 10% would be about 500,000 units of blood.
Okay.
We collect 270,000. So, and then out of that 270,000 Kambua, 75% is used by women, especially the ones who come to deliver. So we don't have enough blood. You asked why women are dying? That's one of the reasons why women are dying. We had an ICU. Remember during COVID? During COVID, there were ICUs popping up everywhere. Unfortunately, some of our leaders did not learn a lesson. We have buildings which are purported to be ICUs, but it's just a building written ICU, a room written ICU. But there's no medication. There's no equipment. There are no personnel. Or sometimes you'll have that room which has the equipment, but it doesn't have the personnel. Or it has the equipment, it has the personnel, but it doesn't have the medications. Okay?
Or the blood.
Yeah. Now, the last thing that helped this lady is that improvisation. Ideally, in everywhere where a woman delivers, we should have these balloon tamponades. Because it's the first thing that you think about. We've checked, there are no tears, whatever. The uterus is not well contracted. Insert it, fill it with fluid. 30 seconds, they've stopped bleeding. It is not them. I commissioned my colleagues from the office of the Kenyan Obstetrical and Gynecological Society, and I asked them to call all the county hospitals and sub-county hospitals. Let them find out whether they have this balloon tamponade. 48% of the hospitals refused to answer. They said, no, we can't tell you. That is classified information.
Right.
It's like, this is...
Unauliza nini wewe?
Where are you calling from? At the Kenya Obstetrical and Gynecology. Hiyo hatujawahi kuisikia. Hiyo ni gani sasa?
Oh my goodness.
So 48% refused to answer. The ones that answered, I think about 35 or 36% had never heard of a balloon tamponade.
Wow.
And women are delivering in those hospitals. Okay? And then now there are very few of them which actually had one or two.
Oh my goodness.
And this is an essential product. Okay? So what helped us to save that lady? Number one, as I said, there's human resource. Number two, we had quality medications. Number three, we had blood and blood products. Number four, we had an ICU. And number five, we had that commodity. Personnel. Of course, we improvised, but it was there. Now.
And the right personnel.
And the right personnel, the human resource.
The human resource.
Imagine in a sub-county hospital, whether you'll have all these pillars at the same time when you need them. You may have the person, may have the consultants, but you'll not have blood. You'll have the consultants, you have blood, may not have the proper medication. You'll have the consultants, you have blood, you have medication, you don't have an ICU. So remove any one of these pillars and our mothers are dying.
They're in trouble.
Talking about excessive bleeding, that BPH, first of all, there's something we call maternal mortality ratios. What does that mean? This looks at the number of women who die in every 100,000 who deliver. Now, this actually is a measure to show how developed a country is. In, we say Western European countries, whatever it is. You find that the maternal mortality ratios are maybe 1, maybe 3.
1 in 100,000?
Yes. Or sometimes there is none.
None.
In Luxembourg, there is none. In the Netherlands is 1. In the UK, I think there are 3 or 4. In Scandinavia, it's the same. You know, in Poland, there are, I think, 2. You know, Belarus is about the same, and so on. In the so-called developed world,
in Africa,
the numbers are less than 10. In the US, the other time, they actually they wrote a big article in one of the journals. Why? Because the numbers had gone from 20 to 23.
Oh, they've
out
gone
of
up
every
by
100,
3.
By 3. It was a big article. what is happening to our mothers and so on. So when they did their study, they found out that actually the numbers had increased because in some places they had closed maternity hospitals because they didn't have personnel. So the distance from residence to hospital is very long. And then of course by the time you get there, etc, you find things have gone south. In Kenya, officially, our maternal mortality ratios are 355 out of every 100,000 women who deliver. That is an estimate, a guesstimate, not even an estimate, a guesstimate. When you talk to international organizations, for example, UNFPA, you talk to UNICEF, World Health Organization, they put our numbers at a lot higher, about 590 out of every 100,000 women who deliver. What does that mean? When you say 590, it means that, let's work with a figure of 1 million women who deliver in a year. It means that out of 1 million women who deliver, we will lose about 6,000 women.
My God.
40 to 45, some say even up to 60% of those women who die, they die because of excessive bleeding.
My goodness.
Which is preventable, in capital letters and underlined. Preventable and what does 6,000 mean in terms of day-to-day activities? So 6,000 you divide by 12 months. When do mtu hesabu?
Mimi si hesabu, wacha nikutolea calculator.
Calculator hapo haraka.
Watu wangu hapa wanifanyie hesabu. Wait, where is my okay, found it.
6,000 divided by 12. So you say, let's say that 1 million women will deliver in a year.
Yes.
And out of those, 6,000 are going to die.
Okay, so 6,000 divided by 12 is 500.
So 500 women die every month.
My God.
So again, we're to calculator. So 500 divided by 30. Let's say a month is 30 days. So
500 divided by 30 in a month. 16. 500 divided by 30 is 16.
500 divided by 30. Sorry, that was in a day because there are 500 in a month.
It's 60,
so divide
16.
by 30.
Yes.
So we lose about 16 women every day. Actually, we have an organization called FIGO. FIGO is the International Federation of Obstetricians and Gynecologists. So it's an umbrella body for all obstetricians and gynecologists in this world. There was a president who came from Egypt. He was a president of FIGO. And he actually made a quote, and this quote haunts me every day. He said, women are not dying because of causes we do not know, because of diseases we do not know. We know these diseases. Women are dying because we have not made a conscious decision that their lives are worth saving. That their lives are worth saving. That's why they're dying. And he was very right. Very right, because if you allocate monies to doing some things which do not have a tangible effect,
a priority,
and here women are dying, then it means we just don't care. We just don't care. Yeah, absolutely.
What can we do, Dr. Kireki?
What can we do? I think there are many things that we can do. Number one, I think advocacy. We have to talk about it until it becomes like a mantra. Remember what happened with the HIV? When HIV started, I think in the 80s, mid-80s, nobody wanted to talk about HIV because it was stigmatized. But when people started dying, and not only, kawaida people, but even politicians, their family, whatever. People came out and said, you know what? My son died of HIV. I lost a sister to HIV. So the public started knowing what HIV is. And guess what happened? Once these information started leaking out or trickling out,
Yeah.
Everything was geared towards HIV. There were HIV programs on the radio, on the TV.
Yes.
When you go to music festivals,
Yes.
there were themes which are HIV themed,
Yes.
protection,
Education
education everywhere. So we can do the same thing.
Yes.
We have to inform our mothers and also our men that when this lady gets pregnant, please go to the clinic.
Yeah.
Go to your nearest clinic.
Yeah.
Once you've done those tests, and it's good that we have community health providers who will pick these women who are pregnant and try to sort of mobilize them and direct them to where they're supposed to go.
Yes.
So that is one thing. So information. Number 2, prevention.
Yes.
Let's start with something simple like anemia. We see patients who come to hospital and have never been seen by a doctor. They don't know their blood group is. They don't know their blood level. They have nothing. And then when you check their blood level, unapata ni 3.4.
Oi.
Unashindwa ala. 3.4. Na mami uko sawa? Mimi niko sawa. Unatembea vizuri? Mimi natembea vizuri. 3.4. Now, for that patient, if she goes to deliver, even if she loses 20 milliliters of blood, PPH, na amenda.
She's gone,
So we need to do prevention is better than cure.
Yes.
If we can catch this upstream and say every woman who comes, who goes for clinic, must have a blood test done.
Okay.
We know what her level is.
Yes.
Anemia affects about anywhere between 27 to 30% of our pregnant women. So imagine if we stopped this anemia upstream upper, we take care of this 30%. We will have taken care of the 30% of women who die downstream because of PPH. So we'll have reduced that number by 30%, for example. So that is something. And then other things as well, which we can identify and diagnose early. Nutrition is important. So as I told you about the younger group, the younger age group, and because them wanakula tu chochote, and you see when you're expectant, you need to eat nutritiously, because remember that baby that he's carrying is actually a parasite.
Right.
Anakula kila kitu and he or she doesn't give you anything. So it's completely reliant on you. So if you eat, madhogodhanio, as they say. Madhogodhanio. So the baby is also not going to be okay. And remember, in that food that you eat, there are minerals and that are important, which will also affect later on downstream when it comes to PPH and so on. So information. Number 2, personnel. We need to have personnel where they are needed. And you see, when you talk about reproductive health, it's the only branch of medicine that is actually put in the Constitution. And it says all of us have a right to quality health care, and especially reproductive health. Because if reproductive health is not there, there's no nation. Hakuna watoto wanazaliwa.
Very important.
So we need that. So we need people. We need to train people. We need to train doctors. We need to train midwives. We need to train nurses. And so on, to be able to take care of these women, and not only train but also distribute them equally or equitably. Why? My organization, we have, give or take, almost 700 obstetricians and gynecologists in this country. 200, almost 300 of them are in Nairobi. Almost half. And then the other ones are Mombasa, Kisumu, the bigger towns in this one. When you go to the arid and semi-arid lands, you find that you may have 2 consultants in a county, or 3 consultants in a county. Mandera, Wajir, they have 2 or maybe 3 consultants, So with these 2-3 consultants, what are you going to do in a whole county? There's nothing you're going to do.
No, you can't.
So we have that, an equitable distribution of the manpower. We need to do that. And this manpower is basically starting from the top, the consultants, all the way, to the porters and so on, because all of them are important. We need medications, quality medications, not fake medications. And then we have to be a bit more serious about what we do, because this PPH can happen to anybody.
Yes.
It can happen to my wife. It can happen to my sister. Just like it can happen to the person who's sitting there and certifying and saying this medication is okay.
Yes.
Because, mimi nitaenda to a private hospital. But even in those private hospitals, it can also affect.
Exactly. Haibagui.
We need blood. Like yesterday. So we need to have a culture of blood donation.
Okay.
We are huge shortfall of blood.
Yeah.
So, and we also need to find a mechanism of supplying this blood, getting this blood to where it is needed at the time it is needed.
Right.
We need ICUs.
Yeah.
Not just caricatures,
well-equipped
but well-equipped
ICUs.
and well taken care of.
And
And then, of course, we need these commodities,
Yeah.
which we need, imagine if we got those commodities and they're available, we'll also take care of about 20 or even 30% of them, of the excessive bleeding.
Right.
So if we did this well,
Yeah.
we can actually make it.
I know that people listening to you are like, okay, I want to donate blood, because that usually feels like low-hanging fruit for a lot of us.
Yes.
How, do people just go to any hospital and ask if they qualify to donate blood?
Yes.
Yeah.
Red Cross actually collects a lot of blood. During our run, actually, Red Cross was there, and it collected, I think, 500 or 600 units of blood, which was a very, very good show.
Yeah.
So Red Cross can actually do that. Any hospital that you walk in, you want to be a blood donor, they will accept you.
Yes.
When you donate blood, of course, once you've donated, that blood has to be tested to see whether it is fit for purpose.
Right.
So they will check it, and they will also check their blood group. Do you know your blood group, by the way?
I knew it.
Sasa.
My husband knows it.
Your husband knows it.
I think I'm O positive.
You think, but you're not sure.
I know it's written. I don't know off the top of my head. If I had a crisis right now, I was like, call my husband.
You see now. Because if something were to happen, you had an accident, we don't know your blood group.
Yeah.
We'll have to use some blood somewhere. So we normally give blood group O negative. That one, you can give it to anybody.
Okay, it's universal.
Yeah, it's universal donor.
Yeah.
Now, but then again, the catch is that is like gold.
Yeah.
There are not very many people who have that
negative.
blood group. So that is why it is important to know your blood group. Very, very important.
Ask me again next time.
Next time. Hakuna shida.
Dr. Kireki, my people will not forgive me if I don't ask some of the questions that they told me to ask you, even as we start to wind up. Somebody was asking about, this is now more around conception.
Correct.
This is a question on ectopic pregnancy.
Yes.
What are the chances of conception and successful pregnancy after an ectopic pregnancy? I lost one tube already.
Oh dear. Paula Sana for losing that tube because of an ectopic pregnancy. First of all, what is an ectopic pregnancy?
Yeah.
An ectopic pregnancy is a pregnancy which grows anywhere outside the womb. Most of the time, it grows on the tube. But it can grow on the ovary, it can grow on the womb itself, in the muscle of the womb, and like that patient that we talked about earlier on, it was completely outside into the womb. Now, the reasons for having an ectopic pregnancy most of the time is because of a dysfunction of the tubes.
Okay.
Because normally, tubes actually do that sort of movement, peristaltic movement, and there's a reason for that. During ovulation, once an egg has been released, at the end of the tube, we have finger-like projections, which sort of cover the ovary. And once an egg has been released, they pick that egg up. Once they've picked it up, usually that is the time a woman feels she wants to have intercourse.
Yes.
And that's the way the body is programmed.
Is that the ovulation?
Ovulation, so that, the egg can be fertilized.
Yes.
So the sperm move and they have to meet the egg at a particular point in the tube. They fertilize it.
Yes.
Millions of them surround that egg, and then it's only kamoja tu ndio kanaingia. Horrible wastage.
I know, and everybody else. Try again next time.
Better luck next time.
Now,
once that has happened, remember that tube does that wave-like movement. It actually pushes the fertilized egg, the embryo, into the womb. Now, if there is a problem and that tube is not doing what it's supposed to do, that embryo will implant somewhere on the tube, and the baby will start growing because it will think, this is the best place that I found. This is where I'm going to live. So that is an ectopic pregnancy. Now, Most of the time, the reasons for ectopic pregnancies, because again, that tube is not doing what it's supposed to be doing. Infections, previous infections, or even previous surgeries. That is the reason.
Yeah.
Coming back to our patient, said she has lost one.
Yes.
So actually, her chances of success have been reduced by half, so she can only use the other side only. And let us hope that everything is okay on the other side, because unfortunately, once you have one ectopic pregnancy, there are chances, of course, the chances are okay, but again, there are other factors which come in. Her age is important, the sperm factor is important, and whatever, all these are important. And then again, it will depend on whether that tube is also okay, because the tube can be blocked as well, and so on. So let her get herself checked first, and then we can be able to advise her properly.
Yes, from there. You've reminded me of a test that I will never forget called the
HSG.
HSG.
Thank you. It's a horrible test. It's a horrible. But I think I have so much respect for women.
Yeah.
Absolute respect for women. Yeah. Yani, that one you...
We will take it.
Tindo, on behalf of everybody.
Yeah, we take it, don't we? We take it.
Because the time of the pain that women go through and the things that women go through, especially to get pregnant, there is no man who can do it. I can say that without fear of contradiction, as they say. It's not possible. And then even once you got pregnant, the things that you, the puking sometimes, the discomfort, and then when it reaches almost term, the baby is everywhere. God forbid there are 2 or 3. You can't sit, you can't sleep, you can't walk. Hata viatu huwezi kuvaa. Alafu mtu anakuja kuchezea mtoto wako. Mwambie wewe.
Women are special.
Very, very special. And all men, we should actually respect all
men. I agree with you. I have had multiple miscarriages all in the first trimester, 4 of them. I carried full-time and lost the baby shortly after birth in 2023.
Oh dear.
And I have been trying to conceive, but it's been a challenge. I've had all kinds of tests done. Over the years, they found I had mild endometriosis. Apart from this, they say I'm perfectly fine. What could be the cause of delayed conception?
Endometriosis. Endometriosis. First of all, Paula Sana, that he has lost 4 pregnancies, and then she loses a baby soon after delivery. It's devastating, absolutely devastating. Now, I think here there are 3 issues. There is the issue of recurrent miscarriage. There's the issue she lost the baby, and then there's the issue of mild endometriosis. The recurrent miscarriages, what we call recurrent miscarriage, is when a woman loses a baby in, before 20 weeks.
Yes.
That's a miscarriage. Now, recurrent miscarriage can be because of very many reasons. Number 1, it can be because the baby was not well formed. Number 2, it can be because of trauma, for example. It can be because of infections. It can be because of diseases. It can be because of the immune system, because a baby is a foreigner in that womb. So sometimes the immune system says, there's a foreigner here, and I don't want this foreigner here. So it starts a system, and that system basically is to try and get rid of the baby, and so on. You may have some structural issues as well, that the womb itself, sometimes the womb is divided into 2. I've had a case or 2 whereby these patients lost their babies, 2 or 3 of them, and then when I went in and had a look, the babies would actually implant where there was a division. And there is not enough blood supply there. So they will lose the baby around 8-9 weeks. Fibroids as well can also be a reason for that, and so on. So she gets pregnant, but she doesn't carry the baby to term. But she got pregnant, carried the baby to term, and the baby passes away soon after delivery. That can be issues, of the heart or whatever it is. I'm not sure whether they did a post-mortem to find out what the reason was. Infections are also a big, contribute quite hugely to this. Coming back to the 3rd problem of endometriosis, it's a big problem, not only in Kenya but worldwide. It affects about anywhere between 10 and 15% of women who are trying to get pregnant, and usually it is an incident of finding. I've been trying to get pregnant, I'm not getting pregnant, what is happening? We do the test, everything is fine, we do a scan, we find there's a structure there, or there are structures there. Or sometimes you can't even see it until now we say we've exhausted all these tests. Let's go and put a camera in the abdomen. Let's do diagnostic laparoscopy. And that is where now you can actually see the endometriosis. Now, mild endometriosis should not be a problem. She should be able to get pregnant. However, you said he has taken time to get pregnant. That can be taken to be one of the reasons, because that is an immunological problem, the endometriosis. But then again, there are also other things which we can look at. She doesn't tell us how old she is, how long she's been trying, and so on and so forth. So she needs a proper workup, as it were.
So please go get yourself checked properly, let your doctor just look through everything.
Absolutely.
But again, yes, we are very deeply sorry for your loss and for just how difficult the journey has been for you. I encourage women to be kind to themselves. Because and I'm glad even when you've spoken about, when you've touched a bit on the miscarriage and explained what sometimes happens, it rids us of the guilt we have. I don't know how to explain it. We carry so much shame.
And actually they say, Daktari, is it something that I did?
That I did.
They ask, and actually it's a standard question. All over. Is it something that, so we sort of carry that blame that it is me.
It is me, I must have done something.
And most of the time, almost 95, 97, 99% is not you. There's nothing that you did. But if you went and started, drinking changa and whatever. And by the way, some of them drink changa and they still deliver.
It's true. And they deliver healthy babies.
Healthy, bouncing babies.
And you who carried yourself like an egg the whole time, you still,
It's life.
It's life. It's life. Dr. Kireki, I'm so grateful for your time and
You're
for just, please allow me to call you again. I have to call you again. I know the women are like, we still have so many questions and there's so much more to talk about. But I love that we've just really discussed on PPH especially. And as we look forward to the run to continue to create awareness, and you've told us ways in which we can all play a part in just bringing those numbers down. I'm just blown to hear that there are countries that are at a zero maternal mortality rate, and I'm like, what can we do to get those numbers to go down?
And sometimes you say, in other countries there are more than 1,000. It's not a comfort.
No, it's not. We are still it's ridiculous.
Every
Our numbers
woman
are
who
bad.
dies is a problem. Unfortunately,
it is. One woman is too many women, and we're currently at about 16 women a day. So this is Dr. Kireki. Do you have any parting last words? You can speak into that if you do.
Oh, yes. I would, first of all, thank you very much for inviting me.
Karibu.
And I would advise our ladies and also the men to take part in this journey, especially once your partner has become pregnant. Please accompany these ladies to the clinics. Women feel protected and they feel okay when they see their partners there. And also, whatever problems there are, there is a solution. Don't die with these problems.
There you go. I will not add anything to it. You have heard from Dr. Kireki himself. Dr. Kireki Omanwa. It's such a pleasure. Thank you so much. And thank you all of you for sitting through this. I know you've taken notes, mental notes. Some of you have written. Some of you will rewatch this. Share it with your girlfriends, your mothers, your sisters, your community. Share the information far and wide. Thank you so much for being with us today. We'll catch you again next time.